Assalamu alaikum. Thanks for the invitation. I'm very happy to share this experience with all of these expert colleagues. So my case is an anterior STEMI and an ECMO-supported PCI. The patient is 59 years old male with hypertension and diabetes in his previous history, presented with 2-day history of chest pain. The ECG was showing persistent anterior STEMI with elevated cardiac biomarkers. Initially was managed by loading dose of aspirin and clopidogrel 300 in a referral hospital and was referred to our hospital for PCI due to the late STEMI presentation. During the procedure, during the LAT ballooning, the patient developed PE. The CPR was initiated for ACLS protocol and the ROSC was achieved after 5 minutes. Then another cardiac arrest for asystole. He received 6 doses of epinephrine, 1 shock of defibrillation. Total CPR time duration was 18 minutes and was intubated on the second attempt. The first one was complicated by tooth fracture. VA ECMO finally was inserted via left femoral vessel 50 minutes into CPR. The patient was sedated, VA ECMO 4 was 4 liters, patient under inotropic support, and the ABG post-ICU arrival, but we will discuss later, was showing lactate 7.4. I will show you the angiography now. LAD was totally occluded at the ostium, RCA was presenting 80% mid-segment stenosis, and Ramus was evaluated as 50%. My personal opinion was a bit more. The PCI was performed successfully, and there was even a complication for the LAD procedure. Final flow was fine, thymic flow was 3, with the residual stenosis 10%. Now, if the video will assist me, I will show you. This was the first one, was the mid-segment lesion of RCA, showed into projection. The left was showing the occlusion of proximal LAD with the stenosis in the ramus. The flow generally was not fine. The patient was wired, the vessel was wired, and after the first dilatation, the patient, as I told you, developed cardiac arrest. We did some dilatation after achieving ROSC, but the patient still was in a very bad hemodynamic condition. So we tried to do a lot of dilatation of LAD, trying to achieve some flow. The flow was restored, but as you can see, we are just coming from the session of no reflow, was clearly not good, my opinion 1. So Van Gans was inserted, keeping the wire there. We started to prepare the ECMO insertion. Still, we were proceeding with some distal dilatation, but as you can see in the bottom left side, the TIMI was not good. So we decided to go for ECMO. In the last sorry, I will go back. In the last, it's clear here, we are trying to get the distal perfusion. That I will comment later about the importance of distal perfusion. Okay. Sorry. So after the ECMO insertion, we decide to provide, as is suggested by the guidelines, even if it's in class 2B, they suggested to perform the full revascularization in patients with ECMO, present ECMO. So we decide to perform PCI on RCA. And finally, we get a good flow even for RCA. This was the echo image after the PCI. As you can see, the ejection fraction was very low. So at the beginning it was 26%. The left ventricular dysfunction was very clear. There was ECMO on site. 3 days after PCI, the ejection fraction improved to 39% with the grade 1 diastolic dysfunction. There was a persistent akinesia of apical mid-segment, and there was a mild pericardial effusion, but no pulmonary hypertension. After 3 days, there was a really clear improvement of the left ventricle performance. Then we need to remove the ECMO, because patient after 3 days was doing well. There were all the criteria to go to the ECMO removal, and we perform it with, firstly, what we are doing, we are checking the coronary artery. You can see that TIMI flow on LAD was much more better. Still, that lesion on the ramus was, in my opinion, to be treated. So we insert the catheter contralateral to see and to protect the vessel that we are going to close. We are checking distally the perfusion by the distal sheet that is performing the perfusion. And then we are going to close with 2 ProGlide the insertion site, but having and keeping the wire for the protection the superficial femoral artery. Anyway, and the left was done by ProGlide, a single ProGlide. This is just to show that everything was fine. There was a small extravasation on the femoral artery, but we managed by manual compression. Finally, the patient was improving. Happy for this. The chest X-ray was not supporting gas, but after a few days, the patient really was extubated, was doing well, and the complication was solved. So after a few days, the patient was discharged after a big discussion with the heart team, with the heart team. The usual scheme of medication was used. This patient was very complex, but which are the teaching points for this kind of cases? Late presenting STEMI is a high risk of mechanical and arrhythmic complication. ECMO during this CPR provide good circularity support, allowing time for PCI, and if it's possible, we should provide the full revascularization for this patient. But the good management of large bore access is a case of success. Post-cardiac arrest care requires multi-system monitoring, not only from the interventional cardiologist, sometimes from the vascular surgeon, sometimes from the neurologist. There should be a good program for this kind of support. Thank you very much.